Mr. Valentine is one of our consultant surgeons in the ear, nose and throat department, both at the Royal Surrey County Hospital and at Nuffield Health. He has been a consultant for 10 years and is a specialist in ear surgery and balance disorders. He will be speaking this evening about diseases of the ear and their links with tinnitus. Please welcome Mr. Valentine.
I've actually been a consultant at Royal Surrey for 17 years, and I started off as an ear, nose and throat surgeon, and I dropped the noses and throats just to concentrate on ears. And within my practice, I manage patients with hearing loss. Certainly. Manage patients with hearing loss, tinnitus, ear infections, balance disorders, and also facial nerve palsies. It's a great pleasure to be to work in a multidisciplinary team with an audiology department that is so dynamic to provide care for our local community. In this 20-minute talk, I'm just going to give a very brief overview of the conditions I see in my practice that present with or affect tinnitus. Now, I am going to give a couple of short videos, which are surgical videos, so if anybody is adverse to watching, I will warn you before I play them. They're not particularly gory, but they will demonstrate very eloquently what can be done to improve hearing loss. So in this talk, I'm going to discuss how we hear. I'm going to then review inner ear hearing loss, talk about presbyacusis or hearing loss of age, noise-induced hearing loss, outer and middle ear conditions that can affect tinnitus, and then otosclerosis, and then finally finish off with Ménière's disease. So that's quite a lot to cover in 20 minutes, so it's going to be a fly-through. So traditionally, the ear is divided into the external ear, the middle ear, and the inner ear. The external ear has the ear canal up to the eardrum. The eardrum itself looks like a speaker cone and collects the sound that is transmitted across the air-filled space by three ossicles, the malleus, incus, and stapes. The movement of the stapes then stimulates the inner ear, where the sound is then, when electrical information is then produced and sent up the acoustic nerves. Now, sound, sound comes into the ear, it's collected by the eardrum, crosses the inner ear, and then stimulates the hair cells within the inner ear. Now, with every movement, sorry, I'm having to do two projectors here. With every movement of the stapes, there is a reciprocal movement of the round window, because fluid within the inner ear is non-compressible. So if we look at the cochlea in more detail, one has there's essentially a rolled-up snail shell. Within the rolled-up snail shell, the sections are divided into three components by two membranes. Now, sitting on the basilar membrane are... Sorry, I'm trying to run two slide projectors at once. So, sitting on the basilar membrane are the outer hair cells, and within the human there are 3,500 hair cells on the basilar membrane that are unique. Taste receptors we lose every two weeks, olfactory receptors in the nose every 90 days, but our hair cells last between 70 to 100 years. And interestingly, in the human eye, there's 17 million retinal cells. So what types of hearing loss do we have? Well, first of all, one can have a conductive hearing loss. That is, the sound doesn't get from the inner ear, or doesn't get from the external ear to the inner ear. Now, by and large, those are things that we can correct with surgery. One can again get a sensorineural hearing loss because those sound waves aren't converted into electrical activity that we then hear in our brain. So, if we look at the basilar membrane, one can see the hair cells, and you can also see where the hair cells become damaged, and you lose the actual hair cell fibers, which looked almost like the field of the basilar membrane had been ploughed. Now, as we've heard, tinnitus represents a symptom of very diverse pathologies, and I'm going to just highlight why one gets hair cell loss. So, first of all, you can have a genetic cochleopathy, that is, you're born with a genetic condition that means that the hair cells aren't formed. One can also have vascular factors that affect the perfusion of the inner ear and affect the longevity of the hair cells. One can get inflammatory factors that can affect the hair cells, and also autoimmune conditions that can affect their activity. Metabolic conditions such as diabetes can affect the hair cell survival, and drugs, and particularly chemotherapeutic agents, can also kill hair cells and have a net effect of causing hearing loss and subsequent tinnitus. Trauma, both in terms of noise and in terms of head injury, causing temporal bone fractures, or actually inner ear concussion, can have an effect. And also some conditions of the bone can also affect hair cells. Now, as we've already heard, that the orientation of the hair cells determines which frequency they hear. So there is a tonotopic arrangement, that is to say, at the base of the cochlea, one hears the high frequency sounds, and at the top of the cochlea, one hears the low frequency sounds. Now that is important in some disease processes because if one gets a middle ear infection, some of the bacteria can produce endotoxins that can go through the inner ear membranes and poison the high frequency cells, and that can be permanent and leave you with tinnitus as a result of that infection. So if we turn to presbycusis, which is age-related hearing loss, in some communities that are isolated, studies have been done to look at essentially what is presbycusis only, that is biological aging. Now clearly these are populations that have been uncontaminated by some of the noxious factors that we encounter sometimes in Western society. But also there are factors such as genetic factors, what you bring to the party and what happens at the party that determine your hair cell survivability. And between the ages of 60 and 75 years old, about 30 to 35% of people start to lose high frequency hearing, which affects their ability to hear speech in noise and speech perception in noise, and particularly the consonant sounds, because one's not able to hear those high frequency fricatives as well. After the age of 75, between 40 and 50% of people have evidence of hearing loss, and tinnitus seems to increase with presbycusis with age. The next very important area is noise-induced hearing loss. Now, this can take two forms. One can have an acute acoustic trauma, that is, one is exposed to a sudden loud noise, where you get a temporary threshold shift, the way the ear feels blocked, and with that, all of us have experienced the emergence of tinnitus. We've all been to a party or a disco or a show where the music's been too loud. We've had the tinnitus that's been intrusive that night, and by and large, the next day it's gone. But sound exposure is a little bit like radiation. There can be a dose to duration exposure. And the more insidious type is that you get a gradually developing noise exposure from either chronic work in noise, which can be at a lower level, or by repeated noise exposure. And obviously, if we guard against this, there are workplace standards and also the requirement for protection at work. But typically, one gets a 4 kilohertz notch, which you're seeing in the audiogram on the left. The pointer is not bright enough. And that is actually typical of noise-induced hearing loss. Now, if one's a shooter, and you're a right-handed shooter, by and large you get the notch in your left ear because the muzzle ear is the ear that catches the pressure wave, whereas the breech ear is relatively well protected. So one can tell whether a patient comes in and you can say, I can see you're a left-handed shot, and they look at you and say, well, how do you know? And it's all on the audiogram. And then as the hearing exposure gets worse, then you start to get the loss that you're starting to see on the audiogram on the right side. So what factors determine noise-induced hearing loss? Well, number one, the work noise, that is the level that you are experiencing. Whether there is impulse noise, now that is by far the more damaging type of noise than constant noise. And certainly I've seen some patients who have been hammering cupboards within a confined noise that has caused them to get the emergence of tinnitus from that impulse noise. So in that situation, it's imperative to use protection. Other such noise exposures, obviously we're talking about military noise, which is very high, and you can't wear protection on the battlefield, and also with leisure. Now some of the in-ear buds that people use to listen to their Walkmans or their mobile phones, those enhance the noise and can damage hearing. Now quite a lot of the phone systems are fixed with a limiter, and which prevents the overplay of sound. But quite frequently people, if they're on a train where there's quite large ambient noise, will turn off the limiter and will be exposing themselves to quite dangerous levels of noise. So if you're on a train and you can hear somebody's headphones with a they're normally about 90 dB of noise exposure. So if they're doing this chronically, they will be causing themselves to have a noise-induced hearing loss. Other exposures such as solvents and smoking painkillers can also make you more susceptible to developing a hearing loss if you're working in noise with those situations. Now clearly your genetics are also going to have an effect as well, and other factors such as blood pressure, raised cholesterol, or whether you've actually got a pre-existing inner ear hearing loss, and whether you have got type 2 diabetes, all have a fact on whether you subsequently develop inner ear hearing loss at a particular level or exposure. So the mainstay really of helping recover is the use of hearing aids. And clearly with hearing aids in, it improves one's audibility of speech. It can help amplify ambient noise and down-regulate the inner ear boost that our previous two speakers were talking about, and can reduce neural activity. But hearing aids are also within the terms of the tinnitus therapy that we offer, the therapeutic side with tinnitus retraining therapy that Hashir and his team run so well. So if we go on to look at the eardrum, you can see, unfortunately the laser pointer isn't that bright, in the top top left corner you see a curved line. That's your chorda tympani, that's the nerve of taste. So sometimes if anybody has had an ear infection, sometimes you can be aware of this strange tingling down the side of your tongue. And that is because the sensation is being referred there very much like as if you were to bang your elbow, you feel it in your fingers. If you get a stimulus of the chorda tympani in the middle ear, you feel it down the side of your tongue. And quite often patients after the surgery I perform have that over a brief period of time, and that generally tends to improve. So if the ear gets blocked, either from wax, which you see on the left, or from a fungal ear infection on the right-hand side, obviously that reduces sound coming in the ear. And then the central gain mechanism turns the amplifier up, and therefore one has the emergence of tinnitus with the blockage of the ear. A lot of patients find this quite distressing. However, by and large, when the ear is unblocked and the normal signal is re-established, the tinnitus in the majority of situations completely resolves. If we look at otitis media, which is a middle ear infection, the slide on the left-hand side is an acute otitis media. That is, there is an abscess with pus within the middle ear space that is causing the eardrum to bulge outwards. Now, as I alluded to with the diagram on the tonotopic arrangement of the cochlea, that some infections produce neurotoxins that can enter the inner ear and poison high-frequency cells, and 9% of patients can have a subsequent inner ear hearing loss having had an acute otitis media. The figure is not known in children. Now, it's not uncommon for adults who have a glue ear, or a middle ear effusion, again because of the relative block in sound, to have tinnitus as a result. And by and large, once the middle ear effusion has resolved, the tinnitus can largely improve. Now what I'm going to do is I'm going to show a video now of putting a grommet in. So this is through a little endoscope or a telescope I put in the ear, and one makes a little cut inside the eardrum, and then you remove the fluid and then insert a grommet, which is a tiny little tube that ventilates the middle ear. In other words, it equalizes the pressure across the eardrum and lets the ear drain a discharge. It lets the inflamed lining of the middle ear resolve, and the ear can dry and the hearing can then be re-established. So this is a view of the middle ear through a little tiny flexible endoscope that's put up the nose. And one can see the stapes, or the little arch of the stapes, which is then attached to the incus at the top. And one can see the eardrum, which we're looking at behind, and the white area there is called the umbo, which is the center of the eardrum from the reverse side. Otosclerosis is a condition that causes initially a conductive hearing loss. And it is due to a rather unique disorder of bone metabolism in the human temporal bone. It exists in about 1%, has a 1% prevalence in Caucasians. And it is inherited as an autosomal dominant in most situations, or there's a spontaneous mutation. What actually happens is you get the formation of new bone at the base of the foot plate that looks, when you're operating it, like an avalanche coming down from the top of the side of the ear, and that development of the bone stops the piston from moving in and out of the inner ear and results in a conductive hearing loss. And so in 75% of patients, they have a bilateral condition. But in 23% of patients, there's also an accompanying sensorineural loss, and it's thought that the area of new bone formation may release toxins to the inner ear that have a negative effect on hair cell survivability. In a recent study, 68% of patients with otosclerosis presented with tinnitus, with 53% being bilateral. And in 35% of people, they presented with tinnitus as their initial symptom. Now, one of the prime managements is amplification with hearing aids, or something called a bone-anchored hearing aid, which is a device that can be attached to the skull to send signals through the skull directly to the inner ear. Or what I carry out at the Royal Surrey is a stapedectomy. And in patients who have an extreme hearing loss, they can be managed with cochlear implantation down the line. I'm now going to show another surgical video. So essentially what one does is remove the arch of the stapes, makes a very small hole in the foot plate, 0.6 millimeter hole. The prosthesis that I'm putting inside the ear is 0.5 millimeters in diameter and is 4.5 millimeters in length. And what one has to do is to gently negotiate that into the inner ear as finely as possible, and essentially place the shepherd's crook over the incus. And this prosthesis that I use allows the crimping, which is the fixing of the prosthesis to the incus with a laser. So by shining the laser onto the nitinol, that changes the shape of the metal and allows it to grip the incus without having to put any forceps in the ear that might traumatize the inner ear. And once you then have got it all attached, you check that it is in fact in the hole. And as you see, as I'm moving the malleus, the whole system's moving, and we've had a significant improvement in the conductive hearing loss. So, following stapedectomy, this really is very successful in treating patients who have tinnitus in the ear. Many studies have shown that quite dramatic improvements are seen, with up to 73% of patients in one series reporting complete cessation of the tinnitus. And a lot of people report a significant improvement in the condition. Now, with every operation, there is a chance that you can have a negative effect, and in my series, about 4% of patients have had worsening tinnitus following the surgery. But it appears that the improvement in tinnitus may or may not be related to the actual hearing improvement. So finally on to Ménière's disease. This is a condition described in 1861 by Prosper Ménière, and he was seeing a group of patients who were experiencing attacks of acute rotatory vertigo going for hours, accompanied by hearing loss, tinnitus, and pressure in one ear. And previously, patients have been managed as though they were insane before Prosper Ménière's disciples, and a lot of them were put on dunking stools as though they were witches. I'm pleased to say that medical science has moved on. It is a condition that is due to, or is very much thought to be due to, a problem with the regulation of the fluid pressure, or the endolymphatic pressure, which becomes greatly elevated. And you can see that on the diagram on the left, that Rice's membrane is stretched by the increase in fluid pressure. Now, this membrane is at its thinnest and widest at the top of the cochlea, where one perceives the low-frequency sounds, and therefore one initially presents with a fluctuating low-frequency hearing loss. So normally, prior to the attack, patients will describe that the ear is starting to feel full, they have a drop in hearing, and they start to get a low-frequency roaring tinnitus. And that builds up, and then suddenly they have an attack that goes on for hours, and after the attack, the pressure, the tinnitus, and the feeling of block improve as the pressure goes off. But then throughout the disease process, as these membranes get more and more distorted by the recurrent attacks, the hearing does not return to normal. And then as the neurons within the inner ear get more damaged, you get a progressive hearing loss in the ear, and the tinnitus generally becomes constant and worsening. And then eventually the condition burns itself out. Now, the modalities of treatment are really directed at controlling the vertigo. And if the disease process takes the hearing, there's very little that can be done. But one very effective tool that we've now started to use is injecting the ear with high-dose steroids. It's exactly the same way as if you get a knee injury, you can get steroids injected into the knee. What I can do is I can numb your eardrum up and fill your middle ear up with high-dose steroids, and those perfuse into the inner ear over a period of an hour in which you're lying on the couch. Now, if we look at the top line with intratympanic dexamethasone, a couple of 3 injections can lead to an 82% improvement in vertigo, but also patients about 50-50 chance of improving the tinnitus in the ear as well. The older therapy of gentamicin treatment, which was essentially removing the balance hair cells with an antibiotic called gentamicin, has the effect of affecting your balance from which you must recover, but also it can be effective in improving the tinnitus as well. So I tend to manage patients with using conservative therapy first, that is, therapies that do not destroy hair cell function. And one of the great new surgeries that has recently come onto line in the last 5-6 years is endolymphatic blockage. So when I was talking about the fluid running away from the inner ear, it tends to move quickly towards the endolymphatic sac, which is a drain at the back of the ear. By clipping that off, you stop the sudden rush of fluid, and this seems to significantly improve the vertigo attacks. But also, again, the patients have a 50-50 improvement to the tinnitus. Now that itself does not affect their balance. And patients who have terrible disease with very little hearing and who have failed all other strategies, our last resort operation is a Labyrinth Ectomy, where one drills out the whole inner ear to essentially render the ear with no hearing and no balance. But that can have the highest effect on stopping the vertigo attacks. And interestingly, one group has reported up to 70% of patients improve tinnitus. So, in conclusion, there are treatments that we have to offer for tinnitus, either directly or indirectly. But it is very much a multidisciplinary team approach. And be kind to your hair cells. Thank you.